Hi, I'm Abreu. I'm at the University of Miami, where I'm director of our Crohn's and Colitis Center, and I'm talking to you from AIBD 2018. This morning I was asked to give a talk on what we need to cure Crohn's disease and ulcerative colitis, and during that session my colleagues talked about positioning new medications for Crohn's and ulcerative colitis, and actually during their talks it's quite apparent, obviously we haven't cured these diseases, so what is it going to take? And what I tried to impart on the audience is that knowledge builds on itself. Even if we had all the money in the world, we probably couldn't cure Crohn's disease and ulcerative colitis tomorrow, because some of the advances that we need are going to build one on the other, not dissimilar from the war on cancer, which is to say that billions of dollars have been spent on the war on cancer, and of course we've made progress, but the progress is at its own pace, and that pace has to do with the nature of science. So I think I would divide IBD sort of into two groups. The garden variety IBD that most of us see, and the kind of IBD that maybe our pediatric gastroenterology colleagues see, where there are children with essentially monogenic forms of inflammatory bowel disease that can be quite severe. And I'll talk about that in a second. But with respect to the garden variety IBD, I think there are things that the disease, when we see it clinically, is telling us something, right? At the extremes, ulcerative colitis endoscopically looks very different than Crohn's disease. What is the nature of that? We know it isn't genetics, right? Because the genes largely overlap between Crohn's disease and ulcerative colitis, although some stars, stand out, like NOD2 being associated with Crohn's and other things like the HLA region associated with ulcerative colitis. But I would argue that ulcerative colitis feels and looks like a disease that is missing certain bacteria or fungus or viruses that need to be replaced, right? And that maybe it's the metabolites being produced by these bacteria that are really the essence of it. Because why else could you flip a switch and have someone flare their ulcerative colitis so abruptly after a course of antibiotics, as an example? And so drilling down to what is missing in a person with ulcerative colitis, I think is going to be crucial. I made the point that the most successful trials of fecal transplant for ulcerative colitis have had to use multiple donors, nightly enemas, a really intense giving back of bacteria, really, because we're hitting in the dark. We really don't know what's missing, and therefore we need to replace without any regard to being refined, because we don't know what it is that we'd like to give back. There could also be a thing where depending on the genotype of the person, you need to give back exactly the right type of bacteria. So that's ulcerative colitis. In the case of Crohn's disease, that really seems like it's plausible that there are certain bacteria that specifically might be drivers of the disease. I discussed the specific case of Mycobacterium avium paratuberculosis, since that has been one of those hotly debated whether MAP is responsible for Crohn's in some cases. It's very difficult to prove or disprove that, not only because it's difficult to identify the bug in patients, it's labor intensive to do so, but also the clinical trials of combinations of antibiotics, I think, haven't really shown a great benefit, certainly nothing near the benefit that we see with things that are targeting the immune system. Again, I still don't find that necessarily tells us that it can't be the cause in some patients, or at least a driver, something that's contributing to inflammation, because even with antibiotics, these bugs may not be touched. I mean, it's conceivable that they're not getting to the right place and that we need to outsmart them. The other bug that I discuss is a very specific type of E. coli called adherent invasive E. coli. That name, adherent invasive, means that in order to define that a person has this infection, you really need to prove it. You need to grow cells in culture and have them invade cells. So again, labor intensive. We're not operationally doing it for patients. Interestingly, this bacterium seems to be resistant to common antibiotics, and so therefore you would need combinations in order to be able to treat it. So again, not discounting it. I really don't like to discount things. I think it's humbling to know that some of the great advances, people didn't recognize it at the time, so let's be cautiously optimistic. What I think is probably more likely is that there are lots of different types of bacteria, maybe viruses, maybe fungi, that in a given individual are what is driving their inflammation. So I also made, I think, the point, and maybe the last thing I'll leave you with, is that I'm a believer that we need to simultaneously, in a patient with IBD, treat the host side, the immune side, probably with multiple targets not just one thing. I think that that's a recipe for escape mechanisms. When you think about anti-TNFs, only get us part of the way, but maybe anti-TNF combined with several other medications. But at the same time, dealing with the microbiome side of things. Unless we rectify that, then we're always going to have a feed-forward loop. We can suppress the host immune response, but if we haven't gotten the microbiome back in check, as soon as that effect wears off, the disease will come back. So we'll see. I'm again cautiously optimistic. I tell my young patients that I hope in their lifetime we'll have made enough progress that they could be one and done, one flare, and that they'll be in remission for the rest of their lives. Thank you.